Okay, welcome back, everybody. I hope you've enjoyed your lunch. And as you're digging into your dessert, we're going to get our programming underway. So, once again, my name is Stephanie Gadwa, and on behalf of the Economic Club of Canada, it's my pleasure to welcome you to our event today. Before we begin, we are reminded and we respectfully acknowledge that we are on the traditional territory and home of Indigenous people, the Wendat, the Anishinaabe, the Haudenosaunee, the Chippewas, and the Mississaugas of the Credit First Nation, land steeped in a really rich history dating back many generations. The purpose of our acknowledgement today is to show our gratitude and our respect for their contributions and to recognize the role of treaty making in what is now Toronto. For those of you who might not be familiar with the Economic Club, we are one of Canada's most trusted podiums of record. We are a nonpartisan national public policy platform that unites leaders, innovators, and experts to discuss and address key issues shaping the future of our country. Our foundation is firmly Canadian, yet our influence spans well beyond our borders. Our commitment to fostering collaboration and promoting thoughtful debate continues to drive so much of the work that we do. The Economic Club is more than just an event podium. It's a platform for transformative ideas, helping to guide Canada towards a brighter and a more prosperous future. Now, we know events like this one would not be possible without the generous support of our sponsors. So a big thank you today to our title sponsor, Merck, and to Johnson & Johnson for being our presenting sponsor. We are thrilled to be with you as the facilitators of Advancing Subcutaneous Oncology, building system readiness across all healthcare. Here to get our program underway is Huang Hu, Senior Medical Director of Hematology with Johnson & Johnson, and she's going to deliver some opening remarks. Let's give her a warm round of applause.
Hi, everyone. Good afternoon. On behalf of Johnson & Johnson, I'd like to extend a very warm welcome today to today's exciting panel discussion, Advancing Subcutaneous Oncology, Building System Readiness Across Healthcare. I'd like to thank the Economic Club of Canada for convening this very important and timely conversation. Across Ontario and indeed the country, our cancer systems are facing increasing pressure. Growing treatment volumes, constrained workforce capacity, and mounting demands on infusion infrastructure are present-day realities for clinicians, administrators, and importantly, our patients. At the same time, there is shared commitment among stakeholders to tackle this challenge by rethinking about how we deliver care. It's not enough to maintain the status quo. We need to adopt new innovation and a new mindset to enact change for the future. Today's panel is grounded in this imperative. Subcutaneous therapies represent more than a clinical innovation. They offer the opportunity to really rethink how and where care is delivered. They bring the potential to reduce treatment burden for patients, optimize the use of limited resources, including infrastructure, and really deploy new models of care delivery to create capacity within our healthcare systems. We are in desperate need of new solutions. But innovation alone is not enough. The real question we're here to explore is, how do we translate this opportunity into practice? From a policy lens, how do we continue to evolve our systems to ensure that they are ready for the safe and effective implementation of these new approaches to treatment? How do we work collaboratively to transform clinic, pharmacy, and nursing models while advancing innovation to drive better outcomes for patients? These are complex questions and they cannot be addressed by one stakeholder alone. That's why today's panel brings together a diverse set of perspectives from clinical leadership, from pharmacy, and patient advocacy to ground this conversation in real-world experience and practical insights. At J&J, we believe in the power of innovation to advance system evolution, and we work alongside these healthcare partners and leaders to tackle barriers, generate evidence, and really to enable a sustainable solution for our healthcare system. It's now my extreme pleasure to introduce our keynote speaker, Philippe Poole, VP of Policy and Government Affairs for Merck Canada, who will explore the broader context for today's conversation.
Everyone, and bon appétit. It's really a pleasure to be here today. At Merck Canada, we've been part of the Canadian healthcare landscape for more than a century, and with deep roots here in Canada. Today, we employ over 1,000 people across the country and work closely with universities, research institutions, and partners across the healthcare ecosystem to support innovation and patient care. Canada also plays an important role in our global research, including a large and well-established clinical trial network. This reflects not only our commitment to advancing science, but also the strength of the Canadian research and talent ecosystem. We're proud to support conversation like this one, bringing together leaders from healthcare, business, and across the life sciences community. This is how we're going to continue to evolve in Canada. But there's a broader context to this conversation. Canada has a long and important history in life sciences. This is a country that has contributed to discoveries that have shaped modern medicine and improved lives around the world. We continue to have strong fundamentals from research and clinical expertise to a collaborative healthcare ecosystem. But at the same time, we're operating in a period of rapid change. Scientific progress is accelerating. Global competition for investment and innovation is increasing. This creates both pressure and opportunity for Canada. The question is how we continue to build on that foundation in a way that benefits patients. Cancer remains one of the most pressing health challenges facing Canadians. 2 in 5 will receive a diagnosis in their lifetime, and 1 in 4 will die from the disease. Behind those numbers are individuals, families, and communities navigating complex care journeys. For many patients, treatment involves regular visits to healthcare facilities, time spent coordinating care, and time away from daily life. These experiences are not the same for everyone, and they can vary depending on geography, care setting, and individual needs. As we look ahead, there's an important conversation taking place about how cancer care is delivered. We often focus on what treatments are available, but how those treatments are administered is also part of the experience. There's growing attention on different approaches to administering certain therapies in specific situations, including alternatives to traditional intravenous delivery. These discussions are grounded on a single principle: the experience of the patient matters. Across the healthcare system, there's an increasing interest in care models that may better align with patient needs and how people live their lives, while continuing to ensure appropriate care and clinical oversight. Some approaches may also support more flexibility in how care is organized. This can contribute to changes in how patients interact with care teams and how services are delivered within the system. From a system perspective, these kinds of shifts may also create additional capacity. How that capacity is used will depend on local priorities, available resources, and realities of each healthcare setting. More broadly, advancing care delivery does not happen in isolation. As we've seen across the life sciences sector, progress depends on alignment. It requires coordination between governments, healthcare providers, institutions, and industry to ensure that policy, infrastructure, and practice move in the same direction. It also requires a shared understanding of the value of innovation, not only in terms of scientific discovery, but in how care is delivered and accessed by patients across the country. In many ways, This is also about ensuring that Canada remains a competitive environment for research, talent, and investment in the years ahead. For leaders in this room, this conversation extends beyond healthcare alone. Access to care and the patient experience are closely connected to workforce well-being and ability of people to stay engaged in their work and in their communities. Canada has what it takes to continue to lead in life sciences. The fundamentals are strong. The opportunity is real. The focus now is on how we work together to ensure that our system continues to evolve in a way that supports patients and reflects the needs of Canadians today. That is what today's discussion is about. And so we're fortunate to have a panel with us who bring a range of perspectives and experience from across the system. It is my pleasure to introduce the speakers for today's panel discussion. Firstly, we have Filomena Servizio Italiano, President and CEO, Colorectal Cancer Resource. Next, we have Cathy Vu, who serves as the Associate Professor, Teaching Stream, Leslie Dan Faculty of Pharmacy. We're also honored to be joined by Dr. Monika K. Krysanovska, Chief, Sunnybrook Odette Cancer Center, and Regional Vice President, Toronto Central North Cancer Program, Ontario Health and Action Network. And lastly, we have Chris Anney from the Globe and Mail that will be our moderator for the thoughtful discussion. Sorry if I butcher your names. That's the French guy trying to do his best here. So please join me in a round of applause to welcome our panel.
Look at the stars, look how they shine for you. Everything you do, yeah, they were all yellow. I came along.
All right, thanks very much. You pronounced my name perfectly fine, so appreciate that. Thanks. Well, let's get started. Lots to talk about and lots of great perspectives. Oops. Monica, I wondered if you could get us started. So subcutaneous oncology drugs are not new, but there's been a lot of big shifts recently. Can you kind of tell us what the landscape is, what's happening right now?
Sure. And Philippe, great job with my name as well. Thank you. So a pleasure to be here. So why are we talking about this? So the subcutaneous delivery of medications is not a new concept. In fact, in oncology, we have been doing it for a long time, but predominantly until now, it's been focusing on what we call supportive care drugs, so things like growth factors or pain medications. What the real opportunity now is that there's a number of new agents coming out that are anti-neoplastic, so actually anti-cancer drugs, so immunotherapeutic agents, antibodies for various cancers. And so that creates a real opportunity for us to be able to develop new models of care and move some of the treatments that we've been delivering in our hospitals and cancer centers into the home setting. And why is this important kind of from a broader system perspective? Philippe's already alluded to this. Our system is at its capacity in many ways. We've been victims of our own success in many ways. We have a lot more treatments for our patients. Our patients are on treatment a lot longer, which is wonderful. It is a wonderful that we're there, but that's creating a lot of pressures on the system and also having a negative impact on the patient experience. And that was alluded to also in the opening remarks. So our patients are having to travel to the cancer center or clinic on a fairly regular basis for prolonged periods of time. So we're really at this perfect kind of triangle where we now have these new drugs that we could deliver in different settings. Our system is kind of at its capacity, and our patients need a new model that would help to support them better. So it's a really exciting opportunity, not without its challenges, but certainly I don't think these are insurmountable challenges, and I'm sure we'll talk about those as the conversation evolves.
Yes, absolutely. But your answer also had a perfect segue to Filomena. So for Filomena, what's the significance for patients of these drugs?
Oh, thanks very much, Chris, and we're delighted to be here. I'm delighted to be here today because this is a well overdue discussion that we're having today, ladies and gentlemen. And Chris, can I have some of Monica's time that she did not use? So, CRAN in collaboration, thank you. CRAN in collaboration with a number of patient advocacy groups actually made 4 submissions across multiple tumor types for 4 immuno-oncology drugs. And we were able to glean patient and caregiver perspectives, priorities, preferences, values when it came to their lived experiences with respect to those 4 immuno-oncology drugs. And this is in the subcutaneous space, and this is essentially what we heard from them. The patient chair time was significantly reduced, going from spending hours receiving an IV infusion to literally just minutes, 1 to 2 minutes receiving a subcutaneous formulation. And this translated to increased productivity for the patient and the caregiver. And knowing that early age onset cancers are on the rise in Canada, patients under the age of 50, for example, can spend the additional time raising their young families as opposed to spending countless hours in an infusion clinic. What we're hearing from metastatic cancer patients in Canada is that the time savings factor is extremely important to them. Time is the most precious commodity that they have available to them when they're undergoing that metastatic cancer journey. They'd much rather spend that additional time engaged in hobbies, volunteer work, spending a beautiful sunny day in their garden, or bringing their children to school, or spending that additional precious time with family and friends. That reduced chair time can help lift the psychological burden of, spending that additional time receiving cancer treatments, long cancer treatments in the hospital, and avoid the triggers of having to watch other patients in the cancer clinic, the infusion clinic, undergo or endure those long treatments. The role of the caregiver can never be underestimated, never. And the reduced time of spending, of actually spending time in the infusion clinic helps to reduce caregiver burden, which translates to fewer, I think the way it was put is they're reducing the burden of having to spend additional time at the clinic so that they can resume their daily routine. They can even go back to work, for example, if need be. While efficacy, safety, and tolerability profiles have been deemed to be identical for both the IV infusions and subcutaneous formulations, what patients are telling us is that they value accessing subcutaneous formulations because it can help to avoid or prevent blood clots, because you're avoiding venous access. And this helps to prevent anxiety, stress, discomfort, trauma, because you're avoiding or you're helping to preserve their veins. They very much appreciate being able to, once again, the way they put it, the convenience and the use of ease of subcutaneous administration. They constantly told us they want subcutaneous formulations. Please have us access subcutaneous formulations because we're in and out of the cancer clinic in just a matter of minutes. And they also told us that preparation time is reduced, monitoring time is reduced, and this is a win-win situation for them.
All right, thank you. Well, so big changes potentially for patients and for providers. Kathy, could you give us a bit of a window into what kind of changes would be needed from providers giving these drugs?
Sure. No, thank you, Chris. And I think great points that have already been raised by Monica and Philomena. But if I think back over the last 25 plus years that I've worked within the cancer system, it's much more complex. And certainly the system that was built then is not what is needed right now in order to sustain our continued healthcare when it comes to cancer care and the different models. The system that we have currently was very much, I think, built around intravenous delivery of cancer drugs. We've spent decades perfecting it or improving it so that it's safe for providers within the cancer system, but also for patients and their caregivers at home as well. But I think the opportunity comes now with subcutaneous delivery is that, can we also entertain taking the treatment outside of the cancer systems, much like what Monica and Filomeno have alluded to? And I think if we think about the providers within the cancer system, the introduction of subcutaneous deliveries introduces challenges, but not insurmountable, certainly. So there needs to be particular attention paid from a safety lens to, if I think along the medication therapy management process, right from the prescribing, that the orders are built in a way that will be distinguished between subcutaneous delivery, IV delivery, so that there are no errors. We have to think about it from a safety lens. In the pharmacy, I think also thinking about where you store your drugs so that you don't inadvertently pick the wrong drugs. And so manufacturers thinking about that lens as well, making the vials distinct. Also from, I guess, from the administration perspective, a lot of times the nurses are used to having half an hour, possibly more with a patient so that they're there, they have their workload, they hang the medications, they go around, they do other things, see other patients. But when you're dealing with subcutaneous delivery, whether it be a 5-minute push or it could be longer, 15 minutes longer or so, the nurse is then sitting at the patient's side. So they're essentially, for lack of a better word, tethered to the patient. But that's not necessarily a bad thing, right? Like, I think there's opportunity in that in terms of forming those relationships, really trying to see how the patient's doing while they've got that uninterrupted one-on-one time with the patient as well. The other thing from a healthcare provider that we need to also think about is sometimes these drugs being high concentration, being more viscous, is from the repetitive strain or ergonomics perspective, right? And really thinking about the work, their work planning, how they're going to, how many of these preparations they may give in a day, how many do they prepare in terms of pharmacy technicians, other healthcare providers within the cancer systems, like our clerks who are booking appointments. What does it look like for chair time in terms of patients who are now only needing 15 minutes to come in? So those, in a nutshell, are considerations that we need to think about for the healthcare providers. But if we get a little bit more creative and we think about outside of the healthcare of the healthcare system as well, can we explore how these medications can be delivered, administered by the patient or their caregiver at home? Are there other community partners, such as community pharmacists, who might also be able to play a role in how we grow and how we innovate our cancer delivery model as well? So maybe I'll stop there, and I'm sure this will come back up again. But yeah, there's a lot to consider and think about. But it's very much agree with Philomena. This is a conversation that is very much overdue.
Great, thank you. And we'll take questions from the audience a little bit further down too. So if you have questions, please submit them. So Monica, you had mentioned too that that there were some challenges to operationally to get these out. Can we dig into that a bit more, and particularly too with the potential of moving things to some home delivery? What are some considerations we have to think about there?
Yeah, so I mean, Kathy talked in a lot of detail about some of the issues within if these subcutaneous medications are being delivered within the cancer center, some of the opportunities and some of the challenges. But moving them into the home, which is, I think, one of the more exciting opportunities, brings additional challenges. So from a prescribing perspective, I think that it would still be the oncologist prescribing, and we'd probably use the same mechanisms. But now we're looking at things like, well, how does this drug get to the patient in the home? Which patients would be eligible for this treatment, for example. And Kathy alluded to, there's different models of delivery of some of these subcutaneous medications in the home, and there's pilots in other jurisdictions looking at either whether that's a nurse-administered product or whether it's self-administration. So there's a lot of factors to consider. So you have to make sure that that you select you match the right patients with the right kind of delivery model and with the drug. So a lot of work needs to be done with respect to that. It depends on the different drugs in terms of stability, right? Like how do you get these drugs actually to the patient's home, right? We do have actually quite a bit of experience with home delivery of oncologic drugs when it comes to oral medications, but oral medications are generally stable. And so the patient can pick it up at a pharmacy and then they can take it home. But some of these subcutaneous medications, they may have specific storage requirements. And so we need to figure those sort of logistics. There's also the policy barrier. I mean, currently for many of the new drug funding, for many of our new oncologic drugs, they're funded through something called the New Drug Funding Program, which is a Ministry of Health program that's administered by Ontario Health Cancer Care Ontario. But as part of the eligibility criteria, this is for drugs that are delivered in healthcare settings. So in order for these types of agents to actually be funded in the home setting, I think we would require some policy change eligibility to that particular program. And then the other piece is obviously the safety piece. There's, patients would often, let's say we make a decision that this particular drug would be a good drug to deliver in the home. This is the right patient. The patient gets the right kind of training, or there's some sort of a nurse-led model that would do this. Things can still go wrong. So you do need to have escalation pathways. And obviously, if we have a patient react in our chemotherapy suite, we have a whole team around them. We have algorithms. We have a team of providers who can sort of swoop in if there's something wrong. If the patient is at home and something is going wrong, you're literally right now left with 911, which is not an optimal experience. So there's a lot of logistical things to figure it out. Is it possible? Absolutely. And there is pilot data from other jurisdictions which shows us that we could build upon, so it's not insurmountable. But there are policy, patient, provider. Actually, one last thing that I should mention before I'll stop and turn over to some of my panelists is provider buy-in. So I'm a healthcare provider as well. I'm a medical oncologist. So I think this is an innovative model that we should explore. But we have to have buy-in from all the other healthcare providers that they feel, okay, I think they would if the system is well designed, if it has proper oversight. I think Philippe mentioned this issue about clinical oversight, that the information is integrated into the health record, et cetera. So if we design it well, I think the providers will buy in, but I think we have less maybe of a perspective on what the broader provider community feels about home delivery, for example, of such an agent.
Yeah, Philomena, what do you think about
Oh, yeah,
my
she
spirit
has.
is?
Yeah, I do. So, Dr. Krasinowska, let's dissect some of that, shall we? This is why it's such a well overdue discussion, because the very first thing that we need to do, ladies and gentlemen, is we all need to come together to ensure that this becomes a priority. What becomes a priority? Ensuring that subcutaneous formulations are delivered in the comfort of the patient's home, and it can most certainly be achievable. Absolutely. Is some work required to ensure that it is achievable? Absolutely. We all need to commit to this, however. And between now and then, amassing the evidence, amassing the data with respect to safety, this is what needs to be overseen so that if there are reactions, adverse reactions, they can be documented so that by the time we get to the point where there is at-home delivery, some of those contingencies can be put in place to ensure no patient is overlooked when at-home delivery is instituted. That's one. Two, healthcare professionals, whether it is a clinician or a nurse who's overseeing administration, patient advocacy groups, patient groups are aligned here. we would be very happy to ensure that we glean their perspectives to ensure that this is a goal that we will all assume will happily glean their perspectives. CRAN would be very happy to ensure that we assume a survey that we can implement nationally to determine if this is something that they would like to see come to fruition. Happy to do that, no problem. And I'm sure that other patient advocacy groups or patient groups will come on board collectively, collaboratively to oversee that undertaking. No problem. What else did you say?
That's enough of a rebuttal.
Well, maybe we'll let Kathy jump in here too if there's something you want to talk about.
Yeah, no, absolutely. I think if we're thinking about taking the subcutaneous delivery and moving it outside of the hospital walls, it definitely can be done. Right now, Ontario Health Cancer Care Ontario also tracks infusion reactions. And so we have an idea of which drugs, and I mean, that's all published in the literature as well. Drug companies have this information as well. But as we're thinking about, as Monica said, the right patient, the right drug, and those would be the drugs that probably have fewer risk of infusion reactions, fewer risk of overall side effect profile, etc. So I think it's a matter of picking the right drug, the right patient, and starting somewhere small. Engage the early adopters within the different cancer centers who are willing to work with Ontario Health Cancer Care Ontario to overcome that the funding policy. I think to wait for a funding policy change is going to take a very long time, and so we need to work within that infrastructure that we have, and there are ways in order to work with cancer centers and still be able to introduce home administration of subcutaneous medications. Again, choosing the right patient, choosing the right drug, and starting small and understanding really what it takes from even a process piece, a communication piece, developing contingency plans. If they do have reactions, who do they call, etc. But also looking at community partners. So for drugs that are not antineoplastic, so hormonal subcutaneous injections, in Ontario, pharmacists, it is within the scope of pharmacists as well, but they need to work under a medical directive. So again, testing that out and slowly choosing the right drug so that we can gain experience, gain some comfort with moving lower risk items outside of the hospital wall. And I think with subcutaneous delivery, the intent is never to move everything outside of the hospital wall, right? I think there are still very complex treatments, high-risk drugs that need to stay within the hospital. But I think, there are other types of medications that can certainly be moved out so that we make room so that patients who need the more higher acuity or the higher risk drugs so that they can receive those drugs in a more timely manner as well.
All right. Thank you to those in the audience who have submitted questions so far. I'm going to read one, our first one now, and I think maybe we'll start. I'll direct this towards you, Monica, first. How will we reach healthcare providers to train them? Where there's incentives to work like this, could there risk to be more labor intensive for external support?
So, I mean, it depends which healthcare providers you're speaking to. I mean, I think so first, I think you need to get buy-in from the clinical teams, and we're having those conversations. So, I mean, we're here today, but in the clinical community, we're having these conversations already. So I think the system, as much as is sort of ready, and there are early adopters that will step forward and work towards figuring out a model. I think ideally we do this in an organized fashion. So I think in Ontario, we have probably one of the most organized systems for systemic therapy delivery in the country, maybe even in the world, through our systemic treatment program on Ontario Health. So I think having them at the table is very important, and they could be a good sort of sort of a good table for them to come together, and probably having some standards would be very good to establish what would this take, what would this mean, and then working together to develop those pieces. So I think so that was the first part of the question. I think I'm sorry. What was the second part?
Whether there are risks that this could be more labor intensive for supporting externally?
I think there are risks. And so the risks that I foresee is that there's a lot of oversight within the cancer centers when we deliver drugs. And there's a lot of touch points, right? So, like, you see the physician to in the clinic, then you're in the infusion unit to meet with and then you see the nurse, the pharmacist interacts with you. So you have a lot of touch points with the clinicians. If you're going to get treatment delivered in the home, there's the risk that you're actually getting less support for patients in the home. So we have to get innovative with how we're going to do that in the home. And we actually, the COVID pandemic, one of the silver linings was the adoption of virtual care. And I think we can actually leverage our learnings from virtual care here. So we could support our patients in the home better through virtual care to get drugs within the home. So I think this is all possible and we can leverage the learnings. We just have to come together and not in silos. Even if we start smaller, you have to have all the right partners. So the government partners, the healthcare providers, industry partners, so all of us together trying to solve this problem, and our patient and caregiver partners, of course.
Great. I want to make sure we have time for a couple more questions. And so I don't know, with this next question, I don't know, Kathy or Philomena, which of you want to take this on, but are we expecting a new budget under the province to support this, assuming it will have to be piloted?
Oh, God.
Always a big ask.
Yeah, there's always that ask. I mean, I don't work, I don't have any inside knowledge, I'm sorry. But I would gather, I would probably say the answer is no, right? We don't have extra budgets anywhere within the healthcare system. And if anything, we're always looking to see how we can find efficiencies within healthcare systems. But I think it goes back to my comment about even without new money coming in, can we work within our existing infrastructure, including looking at drugs that are already funded under the new drug funding program that meets those check boxes, the very low risk of infusion reactions. And the one thing I think we haven't said, and I know Monica and I and Philomena probably also share this, is that first injections will always be done within the hospital setting to make sure that these patients handled or didn't have a reaction or tolerated the medications before we even think about moving it outside of the hospital wall. So I'll just put it out there as an assumption that we are all making. But in terms of picking that right drug, start with something that's already funded and then find ways to move it outside of the hospital in a way, for example, patient self-administration. There doesn't need to be funding associated with that, right? If you're thinking about community pharmacies, there might be reimbursement that might be tied to that, but the cost of providing reimbursement for an injection for a pharmacist or a pharmacy technician to do this is probably lower cost, right? So just thinking about how we find those efficiencies within the system that likely won't see new money. And I don't think waiting for money to come into the system in order to implement this is the wrong approach as well, because we can do it in smaller steps to test out any process, any new changes in care models that we want to consider before really asking for a bigger budget as well.
Okay. And Philomena, any thought about that?
Yeah, I'm just going to share reduced prep time, reduced monitoring time, and of course, reduced administration time improves health system efficiencies across the healthcare ecosystem, which imparts an economic benefit, which behooves us to essentially share from a patient advocacy perspective with healthcare policy experts. And we are prepared to do that. We will do that. We can share the patient perspective, which today is all about, ladies and gentlemen. The patient journey is fraught with so many challenges, with so many barriers, isolation, loneliness. You all know that. They surrendered that control the day they were delivered that diagnosis. if we can just relinquish just a little bit, give them back just a little bit of autonomy and control, and at the same time, maybe, just maybe, save healthcare dollars, it's a win-win situation, my friends. A win-win situation. And we are prepared to move forward to try to ensure we realize some of those healthcare dollars together. From a patient advocacy group perspective, we are prepared to collaborate with as many stakeholders as possible to help realize that. We will move forward in that very confident and competent manner. That's all
Thank
I'm
you.
going to say.
All right. So we only have a couple minutes left, but one last question I wanted to end on was we have talked about some of the opportunities here and some of the challenges navigating it. But one other part of this is the idea that, so, okay, if you move some of the care home, theoretically that opens up some seats, opens up some opportunity in some of the other healthcare settings like the hospitals. What do we think would happen with that? Or what could happen with that capacity?
It will be filled. So we are seeing increasing pressures. I mean, the year over year, our systemic therapy volumes are growing. We have more drugs coming on. Patients are staying on treatment longer, which is wonderful because patients get more time. But as a result, all of the cancer centers or systemic therapy delivery facilities are seeing increased demand for their chair time, which is a term that's used for sort of how many patients you can treat in a day. So many of the systemic therapy delivery institutions are seeing, longer hours, opening up on weekends like Saturdays. It's becoming more common just to meet that demand. And so looking for new solutions is very important. So that's why I think this is a big opportunity that, we're actually, I think most of us are all on the same page. We want this to move forward. It's just about how and what needs to be aligned and how to best work together. So that capacity, unfortunately, we don't have enough capacity. And I think Kathy's point was right on. We probably don't need extra funding. We just need to use the money that we have in different ways and be very thoughtful. So I think we just need to get ourselves together and talk about this and just figure out how to start.
Kathy?
No, I couldn't agree with Monica more in terms of if you free up that space, something else will come in. Because when I think back, when I first started a treatment is maybe in the adjuvant setting, which is more the curative setting up front, 2-3 drugs. If you're in the metastatic setting, maybe 1 drug, 2 drugs. Now we're combining so many different types of drugs, and they're much more complicated, complex as well. And so that capacity we desperately need in order to keep up with the available treatments. However, I think this conversation is very exciting because it also allows us to think about how we might be able to innovate and build capacity by engaging other stakeholders outside of the cancer system. Cancer treatment does not need to belong within the cancer system only. We can work with our community providers and as well as patients and patient advocates. The only thing I'll probably end off by just saying is that we need to consider the whole system, and just by removing one component will also set us up for safety concerns, for errors as well. So as we're thinking about how we do this, we need to think about the whole system and who will be impacted by a change in the delivery or the change in the model of care as well, so that we retain that really high quality and safe system that's been built over the decades within Ontario and certainly across Canada as well.
All right, thank you. Yep.
I'm just going to respectfully disagree about one component, and that's about the governance for the oversight of these drugs. I actually think they do need to stay within the cancer system. We do need to know what patients are getting, that they got it, that it's documented in the record. It can't be fragmented, right? So that's just one comment that I think where I maybe I'm not 100% on the same page because I do think the governance should stay within the cancer system, although certainly we should leverage all of the different community supports that are available because we want to make sure that we know what our patients are getting, that it's documented, etc. Sorry.
Sorry, yeah. Thanks for clarifying, Monica, because I did not mean to say that it shouldn't be within the system. I think the delivery of it does not all need to be within the system, but the governance absolutely does. And I think it loops back to considering the whole system, right? There needs to be oversight. There needs to be that governance structure. So thank you for clarifying.
All right, and Philomena, 10 seconds, last
The
comment.
chairs need to be freed up. Why? Because innovation is coming down the pipeline at an unprecedented rate, and we need to keep up. Those chairs need to be freed up.
All right, thank you very much. This was great.
A big thank you to Chris, Philomena, Kathy, and Dr. Monica for such a great conversation today. I know there was a lot of audience interaction and questions, and I'm sorry we didn't get to many of them, but stay tuned. We will likely do a part 2 in the fall. A big thank you to Merck and Johnson & Johnson for supporting today's luncheon. As you know, events like this one aren't possible without some support, so a big thank you to them. Now, please mark your calendars for our next Economic Club event. On June the 9th, we're hosting another luncheon entitled Scaling What Works, Advancing Health and Healthcare Excellence Across Canada. This will be our final event of our season and one you won't want to miss. You can find all registration information on the Economic Club website. Again, thank you for joining us today and have a great afternoon.